we've had the great privilege of having the top sports cardiologist in the world, Dermot Phelan, with us for a few years now. And Dermot has a special guest that he'll introduce. Thanks for being here, Dermot.
Thank you. So yeah, it was exactly 3 years ago when I came down to give ground rounds here. I was just recounting it. I was just picking up Druv coming down the corridor. So it's, as you said, come full circle here. So it's a great pleasure to introduce Druv Sheshadri. Druv is, I first met Druv in about 2015 when, as a PhD fellow, he came into my office and asked me, did we want to investigate the Apple Watch? So Druv thinks big, and we published a number of papers looking at all these different technologies. Druv is not only just a brilliant mind when it comes to this kind of wearable technology, but also a true gentleman. Druv received his BS in Polymer Science and Engineering in 2014, his MS and PhD in Biomedical Engineering in 2018, 2022 in Case Western Reserve University in Cleveland, Ohio. And during his PhD, Druv actually developed a electroceutic device for chronic wound healing, which spanned its innovation in soft, flexible materials for electrodes and wound dressing, and translated this technology to large animal models in preparation for clinical trials for humans. He's led collaborations with institutions all over the country and indeed all over the world, from Cleveland Clinic, Ghent University, University of Southern Queensland, Atrium Health, UCLA, University Cleveland, on wearable technology for orthopedics and cardiology. He's currently at Civil Health, where he plays a key role in the company's commercialization pursuit of wearable technology and digital health. So Druv, please take it away.
Good morning, Dermot. Thank you very much for the kind introduction. It's great to be with all of you today. I want to talk a little bit about my work in wearables, specifically the application of wearable bioelectronics and digital therapeutics for human health and performance. Before I do that, I'm just going to use the volume. So just a little disclosure, I'm an employee at Civil Health, which is a startup out of Northwestern. As part of my role, I'm also a visiting research collaborator at the Curry Simpson Institute for Bioelectronics. So the work I'm going to be talking today is mostly on the academic front relating to the translation of wearable technology. That said, I want to first talk about the current state of wearable technology, talking about the various domains for these sensors, really from a biomechanical, physiological, and biochemical front, and kind of want to provide a little bit of examples on the clinical validation studies that have been done in the literature to really set the scene for what are the gaps in the technologies today that bring about a lot of the research efforts that we're doing right now. And then we'll talk about addressing these critical paths and the opportunities to innovate. And then I'll talk about, what my interest in leveraging my basic science, basic engineering background with kind of your expertise on the clinical front, to hopefully merge the two together for interesting long-term collaborations. And would love to hear your thoughts if there's anything that's interesting to you and ways we can work together. So the first example I'd like to talk about is wearable tech in sports today. So probably the most common example is your biomechanical based sensors. So for those of you that watch football or any sport, you've probably seen a lot of these sensors that are used today. So for example, the Catapult optimized S5 sensors that are used ubiquitously in the NFL for monitoring stuff like acceleration, deceleration, velocity, distance. Some of these sensors have the capability to monitor heart rate and player tracking. So looking at player movement in relation to the field to optimize player performance and player workload profiles. And so these are just examples of different sensors. So the one on the right is a Zebra RFID chip that's currently used in NFL stadiums today. So they have different triangular outlets that are in the stadiums, and each player basically outfits them in the shoulder pad. So it's one sensor in each shoulder pad, and they're worn during games and practices today as well. And these are other sensors across the market. The VX Sport, for example, kind of looks analogous to a polar device if you look at it from a picture standpoint, but it's also used a company out of Australia, but it's disseminated more to cricket, rugby, and sports that are performed mostly in countries like that. And so from such sensors, we can measure position, distance traveled, velocity, triaxial acceleration, so acceleration in the X, Y, and Z axes, and then compute something called external workload, which is really a change in the magnitude of acceleration divided by a scaling factor. And different companies have different proprietary algorithms that they use to calculate workload. So you've heard of this term, load management. That's one of the variables that is used to kind of define that overall concept. And so from these variables, we can kind of apply it to a wide array of metrics. So for example, player movements in a real-time manner. So looking at, once again, how players move in relation to the field, so you can get their real-time performance and track their specific movements over various plays. We can correlate external workload to then correlate energy expenditure by basically integrating acceleration over time to look at how much energy is the athlete expending. And then we look at movement profiles and zones based on segmenting the data into how fast they're running into per specific velocities. And then we can calculate things like player loads. This is a custom metric that companies such as Catapult use to provide metrics into how hard athletes are working. And then, we can look at, there's been literature papers such as BJSM, et cetera, that have computed ratios such as the acute to chronic workload ratio, which is one way out of several that such metrics have been utilized. It's not the only way, but it's just a way that's been published quite frequently in literature over the last 6 years or so. So what does some of this data look like? Let me just provide an example to you. So this is a study our colleagues in Cleveland did looking at an NFL team over a 2-year period. So this is the 2014 to 2016 period. And in this, they found 136 lower extremity injuries were reported, and 101 injuries with complete GPS and clinical data were included in this study. And so really what they found was athletes with an acute to chronic workload ratio of 1.6 were about 1.5 times more likely to suffer a myotendinous or a ligamentous-based injury. So just to provide some context for this acute to chronic, just to define it, acute workloads can be defined usually over a 1-week period, chronic workloads per literature, and obviously this can be sport specific and position specific, but have routinely been defined as a 3 to 4 week period. So by taking those ratios of that 1 week over the 3 to 4 week period, they get this ratio called acute to chronic, which is one way of looking at it. It's not a one all be all, but just one way people have looked at this. And they found that basically with a ratio of this value of 1.6, about 1.5 times more likely to look at this. And this is the first study to really look at the relationship between external workload and soft tissue injury in professional athletes. So this is some of their data. So the graph on the left really shows player load, so an arbitrary unit, really by the magnitude of acceleration over a scaling factor like I described, over a week. So about a 35-week season, so taking into account the preseason and the overall actual season. And you kind of see the fluctuation in workloads over time with the zero really big when the athletes were not training. And then comparing the workloads between injured versus non-injured, specifically for ligamentous injuries, we see that there is a significant change in workload profiles in the injured versus non-injured cohorts. So this is just one example of how biomechanical data used today can help inform clinical outcomes from a looking at player movement and player acceleration perspective. The next example I want to talk about is the use of the wearable tech from a physiological perspective. So there's multiple devices. I'm sure all of you have or are wearing one or are very familiar with this, but examples include the Polar, Apple Watch, Fitbit, Garmin, but even looking at Whoop, which has kind of gained popularity as a result of COVID with their ability to look at changes in respiration rate and other vitals, heart rate variability, resting heart rate with COVID. So it can measure respiratory rate among and a bunch of other metrics. A couple areas where I've become personally interested, which is one is MSKI, which is a muscle oxygen saturation sensor. So what I've provided here is kind of a breakdown of the sensor, which basically uses near infrared spectroscopy. So if you go back to kind of your elementary college days with looking at drug concentrations with Beer's law, so absorbance is the concentration times the path length times the permittivity constant. That's really how change in the amount of muscle oxygen in the muscle is calculated. So and I'll provide some examples later on in my talk on how we're using the MSKI sensor to look at athletes that are recovering from an ACL tear to quantify these changes in muscle oxygen between the contralateral and surgical leg. So I'll provide an example of that, but this is one sensor that we've become very interested in that regard. Another area we've become interested in is measuring core body temperature in a non-invasive manner. So obviously, heat stroke is a major issue in sports today, whether it's the youth, collegiate, or professional front. So how can we model core temperature non-invasively without either having athletes take a pill or through rectal measurements, which are deemed kind of the standard of care. So that's kind of an active area of research for us as well. There's a couple sensors in the market today that do that, but not with the specificity and accuracy that's needed for appropriate clinical decision making. And lastly, for blood pressure monitoring, there's a lack of devices for non-invasive monitoring. One just being the Omron Heart Guide smartwatch, and I'll provide some clinical data that we actually did with collaborators at the Cleveland Clinic, the Heart and Vascular Institute, where we looked at the accuracy of the Omron Heart Guide smartwatch compared to arterial line. So, but I'll share some data in a minute. But from this, from all these sensors, we can look at a wide array of metrics like I described. And we can look at internal workload. So looking at this metric called TRIMP, or training impulse response. Can be one metric based on your heart rate scores. Stress based on changes in HRV, heart rate variability. Infection status, so based on changes in resting heart rate variability. So there's been a lot of work out of Scripps Institute with Dr. Topol and Dr. Steinhobel, looking and also a bunch of different studies, the tech study looking at these changes as they relate to influenza and COVID specifically. With muscle oxygen saturation, looking at muscle atrophy or changes in deconditioning of athletes as they return to play, either if it's from COVID or if it's from other, or an injury or just during the off season as well. Skin and core body temperature, hypothermia, heat stroke, etc. Blood pressure, looking at rate pressure product as a potential metric for internal workload or even just for monitoring as well. So I want to provide one example of how this is being used. So this is data from a patient who had COVID and was using the Whoop 3.0 strap, and was a symptomatic individual, reported loss of smell for about 3 weeks, ongoing chest palpitations and chest tightening. We basically looked at when the individual tested positive for COVID and also when they received the second dose of the Pfizer vaccine. And the question is, what is the sensitivity of these metrics or specific vitals, specifically respiratory rate, heart rate variability, and resting heart rate when this individual has COVID? So this is when the individual had COVID. So really around day 7 approximately is when COVID-19 was detected. So you can really see on the graph on the far left, the respiratory rate spiked as what you may have seen in literature to a pretty significant amount. Heart rate variability plummeted, along with a significant increase in resting heart rate. So the question is, how does this data correlate if someone were to get a vaccine? So in this case, looking at the second dose of the vaccine, we kind of see something similar in that regard with the same trends in vitals, but obviously on a lower count. But this just gives us baseline data to understand how do these vitals change with someone that has an illness such as COVID. And we kind of then develop these sort of predictive algorithms to then monitor infection status. So this is just kind of give us a case study that I wanted to present to kind of show how this technology is being utilized today for RPM, for remote patient monitoring purposes. And the next area I want to talk about is an area that I've become particularly interested in, is the use of wearables for biochemical monitoring, so hydration monitoring, sweat monitoring, looking at biomarkers from eccrine or apocrine sweat for performance optimization purposes. And so this is kind of our new area of research from a technology readiness level standpoint, where it's slowly been translated from more lab prototypes or minimum viable products to commercial products today. What some of you may have heard of the Gatorade sweat patch. So this actually came out of a lab that I'm part of at Northwestern. So the company's called Epicor Biosystems, headquartered in Cambridge, Massachusetts. It looks at sweat, and this patch here can measure things like sweat rate, fluid loss, sodium content, and chloride content. So this is really what the device is. So it includes a wicking layer. So it basically uses microfluidics to wick the sweat up from the skin. They call it epifluidics. So basically can detect sucks up microliter volumes, about 25 microliters of sweat. And then there's a colorimetric agent in the sensor, which once the sweat is absorbed through the microfluidic channels, basically changes color. And using a camera, you can then correlate the changes in what you're seeing from a color standpoint to the concentration of the analyte that you want to measure. So you can look at looking at hydration status, how much fluid you've lost. You can also look at your sodium loss, and also now they've started to add chloride as well. And I'll present some data on that in the next slide. Another sensor out of Boston, the NICS biosensor, can look at something similar, such as sweat rate, electrolyte loss rate, and sweat composition. And there's also a couple other sensors that are not yet fully available, but can measure interesting parameters such as hydration, core temperature, sodium, and potassium as well. And so kind of using this, what can we look at? So for example, obviously sweat rate, as all of you know, we look at fluid output, consumption. Sodium could be looked at dehydration, skin health, hyponatremia. Lactate, which has kind of been a big interest of ours, has been looking at workout intensity, anaerobic threshold, et cetera, or even cortisol measurements, which has been some work out of Stanford where they've correlated that to cognitive function and a metric for stress levels, as well as, once again, in a non-invasive manner to mitigate blood draws, which are conventionally used. And so I want to just kind of give some examples of what some of these sensors look like. So there's really two ways that sweat can be measured or extracted from the body. One is through passive modalities, the other is through active modalities. So passive basically means you have an athlete that's sweating, you put a sensor on them and it wicks the sweat and is able to measure it. So these are examples of flexible, soft, flexible, stretchable, microfluidic sensors that basically are adhesive. So they're basically the size of a quarter, just to put some in terms of a size perspective for all of you. And they basically can stick on any location of the body. So the soft, flexible nature of the material, in this case silicone, enables the adhesion to really the irregular topography of the skin. And so some of these are waterproof. So in this case, this is a swimmer at Northwestern competing in the NCAA championships. So our colleagues basically put the sensor on him, so you can actually see it being used real time. And this was actually done. So the last 3 images were a paper that was published in Science in 2019, where they put the sensors on an athletes at the Ironman in Kona, Hawaii. And they basically and they basically using the sensors were able to quantify sweat rate, whole body sweat rate, and other biomarkers such as sodium, potassium, and even skin pH as well. So this is passive based. In other words, you don't have to deliver any agent into the skin to monitor sweat. The other way to do it is through active-based modalities, which is where you introduce some agent or deliver current into the skin, or such as reverse ionophoresis is a common method to wake sweat up. So from a standpoint of athletes, this is not probably the most opportune way, but if you're looking at patients, for example, with cystic fibrosis, if you want to look at chloride levels, obviously you don't want to exert them too much. So this is one potential way to do so. So the image on the left was from a group at Berkeley. So the paper was published in the Proceeding of the National Academy of Sciences in 2017, where they basically developed a wearable wrist monitor that could deliver current to wake sweat. And they were able to measure, in this case, chloride. And they did testing at UCSF on patients with CF and were able to show correlations with that in blood draws to demonstrate the efficacy of their sensor. And the graph on the 2 images on the right was a group from the University of Cincinnati, the Heikenfeld group, published on Lab on the Chip in 2019. This is for ethanol monitoring. So one example, this was with interest to look at, is there a non-invasive way to help policemen for DUIs or other applications as well? So in this case, it basically has a sweat stimulant, so it delivers a agent into the skin to facilitate the release of sweat. And there's an active agent that basically wicks the sweat. So the hex wicks sweat sampling. So the sweat comes up, and once again through these microfluidic pores, is able to measure sweat, and then can detect, say, metrics such as ethanol content from the sweat itself. So let me show you some data and what some of this looks like. And so these are just kind of 2 papers I want to present. One is published in December 2020 in Science Advances. This is the Gatorade sweat patch that was developed. And so these are actually on athletes right now. This work was published, or these trials were done at IMG Academy in Bradenton, Florida, where they put these sweat patches on athletes, have them do a bunch of sports. In this case, this was a soccer athlete. And then what they also have is looking at the relations between internal, external workload, internal in this case based on biochemical output, but also can measure external using the GPS sensor that this athlete is wearing. And to validate the efficacy of this, they used an absorbent patch where they basically absorb the sweat and then just use lab-based metrics to quantify whole body sweat loss. But they also had a microfluidic patch of this Gatorade sweat patch that the athlete was wearing to correlate the relationships between the two. And they found that there was the sensitivity and the correlation was great. And then another paper was looking at vitamin levels and other calcium, zinc, and iron levels from sweat. And so this is a picture of a sensor here, and on the right is a picture of a vitamin C pill. So what you can see is the form factor of this integrated technology is on par to what someone may take orally. And so we're able to manufacture these kind of leveraging Moore's law and fabrications and flexible electronics to get them at a form factor to make them as unobtrusive and non-invasive as possible. And so these colors in this patch is the colorimetric agents that I've described. So when you sweat, it basically changes color, and then you can take images of them to then correlate to the various biomarkers that you want to measure. So in this case, for vitamin C, that a correlation coefficient of around 0.93, 0.74 for calcium, around 0.9 for zinc, and about 0.96 for iron. So this is just one area where, from a patient perspective, how such technology could potentially be applied. So I want to show you some data now about some of these sweat sensors. So looking at, once again, the Gatorade sweat patch, just going to break it down into the components. What I've done is, if you look at something that's like several microns thick and kind of expanding it out, what does it look like? So basically we have the epifluidic channel that I described, and with the colorimetric agents in this black box. So, and then we have a skin compatible adhesive. So these adhesives are what you would find in your commercial Tegaderm or anything that you would use for patients. So it's usually an acrylate based adhesive. And so you basically put this on the skin, you peel it off, you stick it on. So you're trying to make it as easy and as simple for the athlete or for the patient as possible. The sweat gets wicked up through these pores, kind of goes through these epifluidic channels that you see here. And then that basically causes the change in color of these agents, from which we can photograph. So the image on the left, apologize, the lighting may not be the best to see these images, but you can basically see the wicking of the fluid, of the sweat that's kind of going through these serpentine channels. And then these kind of guides to quantify the change in color with what's being shown. And then the image, so using an iPhone or an Android, you can basically take a picture of the microfluidic patch. And then from there, you can get your sweat profile results, such as sweat rate, your sweat loss, your sweat sodium loss, and then provide some sort of actionable feedback to the athlete to tell them how much water, how much fluids they should consume. And then looking at internal workload based on TRIMS, based on RPE, so rating of perceived exertion, so the duration of your workout, as well, multiplied by your specific score out of 1 to 10 will give you your internal workload. So you can correlate all of this together in an integrative analytical app, essentially, is what they've done. And so the question I asked is it really accurate? And so this is looking at the relationship between, say, a microfluidic sweat patch and whole body sweat rate. So the image on the right is for chloride content, and you can really see a correlation around 0.93. And similarly on the left for sodium content, so whole body sweat rate for sodium versus whole body sweat rate for chloride, a correlation coefficient of 0.99. So we showed, so what we found from, what the researchers found really from these epifluidic patches is that they are representative of what you would want for potential clinical decision-making purposes. But more importantly, what this work highlights, at least for me as an engineer, is this translational potential that kind of occurred. So a lot of this started out as fundamental science, fundamental material mechanic interfaces, looking at stretchable, flexible electronics about a decade ago, a couple decades ago, when the miniaturization of electronics really started. Developing a platform technology, this epifluidic platform technology, where using silicone microchannels that can be fabricated in the lab, and then to really get a platform product, and then translating that out from the lab into a company, and then licensing out to Gatorade to make the Gatorade sweat patch, and then developing partnerships with, like I said, with Gatorade or even with Chevron now, which really kind of shows how translational pathway of academics is something that is really important to ultimately address unmet clinical needs. So an area that where I feel the wearables can go is really, if you take RPM, really the intersection of sports medicine, COVID-19, and RPM. And so I'm not going to say too much about RPM because all of you are probably experts in this, but really by the year 2025, approximately 26% of the United States population will use some sort of RPM technology, whether that's some sort of mobile device, whether it's a wearable, there's a bunch, or some sort of modality to track their health, to predict their health, or a way to interact with the clinician in some regard. And there's a study from the UPMC that found the use of RPM decreased readmissions by about 76%, improved patient satisfactions by greater than 90%. And about 70%, and then in a study at KLAS research found, with looking at 25 healthcare organizations, 17% of these organizations cited cost reductions using RPM technologies. And so really from the standpoint of what can be done next, it's really the miniaturization and interoperability, I believe, that's kind of driving the next step. So how can we get these electronics in a more non-invasive format? How can we mitigate iatrogenic skin injuries? For example, if you have devices such as the Zeo patch or other epidermal patches that may cause skin injuries, can we develop better adhesives that there's no irritation on the skin? Interoperability. Can these sensors be integrated into medical monitoring platforms such as Philips EC10 or Draeger, et cetera, to reduce nurse burden, but also improve patient satisfaction? That's really been a really important area of mine, is what we can certainly develop wearables to measure whatever we want it to measure, but if it's not helping the end user, then in my opinion, it's pretty pointless to engineer. And so translating this over to athletes, this is a paper actually, Derman and I and a bunch of others just submitted last week to Nature Digital Medicine, looking at the role of this technology for remote athlete monitoring and how can wearables be used to kind of fill this gap. And so really, if we start with an athlete in an injured state, you can measure parameters such as heart rate variability, respiratory rate, muscle oxygen, really the parameters that I've described thus far. And say, for example, if an athlete were to test positive, this data gets sent to a team physician, to an athletic trainer, to a head coach. And then to form the return to play, or the minimal clinically important difference. So the MSKI, which will basically assess the return to play status to get the athlete to where they need to be. And so we can kind of use wearables to then measure some of these parameters, knowing their baseline to figure out where they need to be. And then for the return to performance or their substantial clinical benefit to get them from the MCID state to the SEB state using, say, like a performance score over time to get them to where they need to be. And we can then ramp up their subsequent training by a scaling factor if we know what they need to be. So in this case, 30% when they're injured to 60% and 90%, for example. These are just numbers that have been presented in the literature. Of course, it's going to be athlete specific, team specific, position specific. And these numbers obviously will change based on the baseline data that's collected in the specific athlete that's being studied. But there's one way that we believe that wearable tech can be used to inform and provide quantifiable evidence to, during the return to play process. So wearable tech has really come a long way. So I just want to provide one context, a little bit of inspiration. So the image here is from 1902, is William Eindhoven in the Netherlands with the first ECG. So you can see Eindhoven's triangle, as all of you probably know. So this is him recording his first ECG with his leg and actually a bucket of salt water connected up to various monitoring. And so this was the first time in 1902. Looking at today, we have 12 leads that patients are connected up to monitor, and then the rhythm strips are printed out and then adjudicated by a cardiologist. But really the cool part about this whole wearable tech is, once again, making it unobtrusive and non-invasive. And so this is an excellent review that was published in Nature Reviews Cardiology last year, looking at how wearable tech can be integrated into the clinical workflow. So for example, the user or the patient will collect data and interact with their device. The data is then, the algorithms in the device are then processed, data analytics are performed, the data is visualized. That gets sent to a software processing and data storage platform. For example, AWS is one example. The data is then sent back to the patient where there's intervention and information that's provided, and also sent to the clinician for actionable clinical data that can be interpreted. And then based on the appropriate data from the algorithms, but also with the expertise of the clinician, and then provided back to the patient to figure out what is the appropriate next steps. So this is, I believe, kind of the appropriate pathway. Using the ECG as one example. So in this case, this is using, say, a device such as the Apple Watch or other wearable devices for cardiac monitoring as one example that is being done and can be done in the future. But before we really dig into this, we really need to understand the efficacy of a lot of this data before we deploy it to patients and to really understand what the clinical gaps are. So when we look at what's being done right now, like I've alluded to, the critical path elements are: one is the clinical trials are towards defining efficacy are limited in healthy individual cohorts. There needs to really be transparency in algorithms. So this whole black box algorithm, for example, if you're going to predict what, if you're going to say, look at someone's recovery score, what is that algorithm? What are the various variables that are going into really understanding what that means? So how do we translate or make that open source, which is a big, which is very important to me. When we want to look at data to show efficacy in such technologies, we often need longitudinal randomized clinical trials that are needed to really objectify or quantify the value of this technology, specifically for RPM or for other applications. And then the integration of this collected data to measure advanced digital biomarkers. So for example, if we want to measure metrics such as cuffless blood pressure, what are the different measurements that are needed? Is it pulse arterial time, or is it PPG? What's the appropriate metrics that are needed to be collected to enable the development of these predictive platforms for such measurements? And of course, interdisciplinary teams, so that really the clinician and the engineers and the data scientists need to work together in the same room to accomplish this. And so these are what I believe kind of set the scene for what should be done next. Is validation studies on using healthy norms to get that baseline data and then translate that over to patients. The opportunity for wearables to guide return to play, whether it's from a musculoskeletal perspective or cardiovascular perspective. The opportunity to innovate in materials engineering and data science. So really to help mitigate, for example, iatrogenic skin injuries, whether it's the innovation of new materials for adhesives as one example, or if you have multiple devices, enabling time synchronization of devices so that you're measuring all the parameters at the same time scale. So you basically are looking at everything in an accurate manner. But one thing that I've learned recently, and what I started to do more and more, is this communication with the FDA. Engage early and engage often. So really get them to, let them know where you're at in the development process and allow them to kind of help you to ultimately translate that technology out. And so from a sports medicine perspective, so this may be of interest to a lot of you in the audience. is it actually looks decent when tested under ideal conditions. So if you bring an athlete to the lab where it's a controlled environment, it may be the data may look pretty standard as to what we want to expect. But given the athlete's performance in dynamic conditions, test the technology where the athlete is. So take it to the field specifically is one. Two is how accurate is the tool when strapped to players of various skin tones and ages, conditions, injured versus non-injured. There's been some really interesting work out of Jesselyn Dunn's group at Duke University in the biomedical engineering department, looking at the role of PPG technologies in different skin tones and finding that there is some sort of discrimination when it comes to PPG and in that regard. So that's two. How does the signal quality filtering and interpretation? This is more of a signal processing perspective. Look for those, for example, who toss and turn at night, get up, experience ectopic beats, or have episodes of sleep apnea. If you're trying to do sleep, if you're trying to measure sleep or other metrics, it's going to be offset based on what the patient is undergoing. How often is the data interpreted? Misinterpretation of data is a huge issue right now. A lot of times our individuals showing, say, decreases in HRV or increased stress levels because they're scared or nervous of being monitored. That's something that we need to take into account. But more importantly, does the collection of data reduce trainer burden and improve the operational efficiency among the sports medicine team comprised of the clinician, the performance staff, and the coaching teams? Ultimately, we want this to make the process more efficient, to expedite their decision-making processes, not be a burden and slow down, what they're trying to do on a day-to-day basis. One of the big focuses right now, or in sports medicine, is there's too much focus on predicting injuries based on single variables. The goal should really, in my opinion, should be to optimize performance by integrating various parameters and including cognitive factors, external, internal workload, athlete response questionnaires. I believe all of these have a different purpose, just taking them into account rather than saying we're trying to predict the probability of injury based on a sole variable. So that's another issue. But more also picking the appropriate technology. What do we want to measure? Why do we want to measure it? How does that technology work? How do we go about measuring it? So these are all questions that need to be factored in when we kind of figure out how do we innovate in sports medicine, is kind of leveraging wearable technologies from my vantage point. So I want to provide some context of some accuracy of some of these technologies to kind of give you some context of where's the literature at and what are some of these accuracy numbers that I've discussed before. So this is a study actually published by one of the sports scientists on the San Antonio Spurs. This was in PLOS, published in about a few years ago. So in this study, they looked at the efficacy of the Catapult Optimi S5. So this is one of the first sensors that I introduced in my talk. And they looked at 19 of these sensors, mounted them to basically aluminum brackets, and subjected them to a series of oscillations, specifically front, back, side to side, up and down, at 4 peak accelerations. So the various G's are provided there. And they basically calculated the workload the same way Catapult does versus the player workload profile that the Catapult sensor outputs. And so this is the only equation that I'm going to be showing today, so I'll explain this. But basically, if we just kind of start working our way back, right? Velocity, obviously, is the change in distance over time. Acceleration is the derivative of velocity. And there's a metric called jerk, which is the derivative of acceleration, right? So in other words, the jerk is the fourth derivative of distance over time. And so what the player load calculates is basically this change in acceleration over time, basically by a scaling factor. So it's really focused on this fourth derivative. And so in short, what did this device find? The Catapult reported player load was consistently lower by approximately 15%. And this is important because if Catapult, Catapult is a technology that's ubiquitous in sports medicine and used by over 100, probably a lot more teams worldwide for workload monitoring, load management profiles. So the fact that it was about 15%, the question then is it clinically significant? That's when longitudinal studies are needed in that regard. But what the authors concluded is that there's a need for industry-wide standards in reporting validity, reliability, and the magnitude of measurement errors. And then it is recommended that device reliability and accuracy are periodically quantified. So this study sets the scene that technologies that we think that are ubiquitous and translated out need to be brought back to the lab for fundamental analysis and testing periodically. And so I thought this was pretty interesting that technology like this, that was lower by about 15%. Next, I want to talk about the efficacy of wrist monitors. So this is a study published, one of the first studies published in 2017 in JAMA Cardiology, Dermot was a co-author on the study. So this was looking at 50 healthy adults. Exclusion criteria included patients with cardiovascular disease, pacemakers, treatment with heart rhythm medications. Each patient was given was asked to wear ECG leads and provided a Polar H7 monitor, and was randomized to two of the heart monitors or wrist monitors probably listed below. So the Apple Watch, Fuse, Fitbit, or the Basis Peak, and they were placed on a treadmill. And what they found was the Polar H7 compared to, say, the ECG had a concordance correlation of 0.99. You kind of see the correlation drops for each of these wrist monitors. And so this was really the first study to look at the efficacy of these in a healthy cohort. In another similar study, looking at different workout instruments, such as specifically the treadmill, the bike, and the elliptical, this is a study looking at 50 healthy adults. And so this is another study published from the Cleveland Clinic, published in 2017, and the various exclusion criteria are provided. And so each patient was asked to wear a standard ECG lead, provided a Polar H7 and a Scotch rhythm device, and randomized to the two wrist monitors below. And overall, from the study, what we found is, you can look at the concordance correlation coefficient of these various devices around TomTom Spark about 0.83, all the way down to the Fitbit Blaze of 0.67. So once again goes to a lot of these some of these devices use PPG-based modalities for detection. So looking at signal processing as one way to kind of rectify the noise once an individual is on these instruments or these various exercise machines becomes critical towards maximizing their accuracy if athletes were to use this technology. So these are just two of many different heart rate validation studies that have been published in the literature. Just wanted to share a couple with you this morning. And so what the overall conclusion thus far from these studies, and kind of aligns with what conclusions from other people, is the use of Polar may be the most opportune when you need heart rate monitoring in athletes or during dynamic periods. And next, I want to share some work from our end was looking at the efficacy of the Apple Watch 4. So this is work that we've done in Cleveland Clinic. This is published in the journal Circulation. And the first question we asked was, how accurate was the Apple Watch 4 at detecting atrial fibrillation, or AF, when atrial fibrillation was detected on telemetry? And so as far as detecting sinus rhythm, the Apple Watch had a sensitivity around 72%. When the PDF interpretation, so in other words, we would take the ECG on the Apple Watch, have it downloaded to the phone, and then a cardiologist would be blinded to the specific rhythm. The cardiologist would then adjudicate that rhythm strip and provide the diagnosis. And what we found was for detecting sinus rhythm, it had a sensitivity of around 98%. Now the question is, if patients have atrial fibrillation, this was atrial fibrillation following cardiac surgery. So with regards to the Apple Watch's ability to notify patients that had AFib, it was around 38%. And then from a pediatric, 3%. Sure what happened there. Okay. And so this is really the first study to look at, what is the efficacy of the Apple Watch in patients following cardiac surgery. And in a subsequent study, we looked at how accurate was the Apple Watch at measuring heart rate compared to telemetry. And so what we found was in patients that had AFib, surprisingly, the Apple Watch was more accurate, had a concordance correlation of around 0.86, but no AFib was 0.64. So this is something that's quite interesting. Why did this occur? And from an engineering perspective, this is something we're still continuing to dive into. Usually these patients have some sort of edema or other sort of complications. So why is it that caused these patients with AFib to have a higher correlation with telemetry compared to no? So that's no AFib. So this is something we're continuing to look into. If you have any ideas, happy to talk further. We still have not been able to explain these results yet, but at least this is what the data shows so far. The next area that we've been interested in is the wearable technology for blood pressure monitoring. So from the 2021 European study for hypertension, really, as most of you may know, there's really upper arm couple telemetric devices are really kind of the go-to for blood pressure monitoring today. However, they're limited, they're intermittent, they're static-based measurements. Blood pressure is dynamic, so how does that change in daily life? And also there's issues with cuff inflation, discomfort, or other issues posed by current blood pressure monitoring devices today. So we want to look at non-invasive detection of blood pressure. There's really three modalities that can occur. One is using PPG or photoplethysmography, so using light. There's one device by Valence Cell, which is not FDA cleared, where they claim to be able to measure blood pressure. So this is using earbuds. So for example, for the Apple Watch, for phones, if you have the AirPods. So something similar to that type of modality. Also using pulse arterial time. So the ANE1, which is an FDA cleared device, but it's not for blood pressure, which is the device shown here. So the chest device and a limb device. Fitbit, which recently came out with an ability to monitor blood pressure, not yet FDA cleared for that. But for oscillometry, the Armor on Heart Guide smartwatch, which received FDA clearance several years ago for blood pressure monitoring. And I'm going to talk a little bit about Armor on Heart Guide and some data that we've done, some work that we've done there. And so in this study, we looked at 50 patients, post-operative cardiac surgery patients that were enrolled within 5 days of being post-op. And what we found was pretty interesting, that there's a variability in blood pressure readings resulted between arterial line and the watch as blood pressure increased. So for diastolic pressure, the concordance correlation coefficient with arterial line was about 0.49. For systolic blood pressure, the correlation coefficient was 0.43. For heart rate, the devices were pretty good with concordance correlation of 0.98. And so these are some of the data here for the top two graphs demonstrate diastolic blood pressure. The bottom two are systolic blood pressure to kind of show the spread in the data in these patient cohorts. So basically it shows that further validation of such technology is needed before application to patients. And so when I share this data, because ultimately if we want to translate a lot of these remote monitoring capabilities to athletes, there's still a lot more work that needs to be done, but also there's other variables that can be counted to play when we want to talk about the exertion profiles of athletes as well. So when we talk about the athlete today, when we talk about training load, a lot of the work, like I've mentioned, alluded to so far, is focused on the physical profile or the biomechanical profiles based on external workload. But there's other variables at play, such as the physiological, the cognitive demands, and the biochemical profiles. We can measure the physical load pretty easily today. As like I mentioned before, there's numerous sensors that can accomplish that. But how can we be measuring the holistic demands of the athlete? So just want to put some things in context here. So training load, like I mentioned, there's really four key factors: the physical, physiological, cognitive, and biochemical. In the physical, we can look at external workload. So there's some work we've done that has shown about a 95% concordance correlation between total distance and the workload profiles of athletes. I'm looking at changes in acceleration or the magnitude and acceleration and its correlation to workload profiles, external workload. From a physiological perspective, internal workload, looking at RPEs or rating of perceived exertions. Different scales to do that, the Borg scale, the Foster, there's different ways we can accomplish that. Heart rate, from which we can then calculate using max heart rate, resting heart rate, etc., and can calculate training impulse responses. I'm looking at blood pressure, which taking blood pressure times systolic blood pressure, we can look at rate pressure product as a potential indication for how hard the myocardium is working. SMO2 or muscle oxygen saturation levels to look at specific muscle physiology and potentially quantify workload in those specific muscle groups. Cognitive, so behavioral, so this is more questionnaire based. So soreness, mood, stress would obviously all play a role in how hard athletes will be working the next day based on how they're feeling. So, and another interesting and emerging area is neurophysiological. So looking at sleep as a variable to incorporate that. So with more and more devices such as Whoop, for example, being able to quantify sleep, measure sleep, how does that factor into the overall process for athletes? And biochemical, an area that is just recently starting to be used, still a long way to go, but looking at whole body sweat rate, sodium levels as two metrics out of many that can be indicative of the overall training load. So really, all of these need to be factored in when we look at how athletes are responding on a day-to-day basis. So when we look at athlete monitoring, right, so the injury or musculoskeletal injuries are a multifactorial process, and workload is just a single variable to maximize performance and reduce injury burden ultimately. So when we look at what can be measured, we can look at internal workloads, external profiles. It can be subjective or objective. So subjective be like your wellness surveys, your session RPEs. So in other words, you ask an athlete after a specific session or after their practice, how hard was that workout? And they would give you a number between 1 to 10 to tell you how hard that workout is. And by knowing how long they've worked out for, say, for example, an hour, you can take that number, so 60 minutes multiplied by the score, if it's a 5, for example, and get a number of, let's say, 300, and that would give you your internal workload, which is a subjective, common way that internal workload is reported by teams today. And then you can look at external, look at movement-based parameters. So these are just some of the ways that are employed and starting to be employed by teams to look at how hard the athletes are working. But one of the issues today I'm sure a lot of you know this. You see youth athletes on a day-to-day basis. This whole concept of youth sports specialization, in an area that's become important to me as an athlete growing up, is how can wearables be disseminated to youth athletes or to high school athletes? A lot of this technology right now is predominantly used in your Division I athletes, your professional athletes, but how can we make low-cost technology and translate that over to the youth athlete front to help prevent or solve this problem, right? Wearable tech is not going to be the single solution to this, but how can we better monitor, track these young athletes to prevent, overuse injuries at such a young age? For example, Tommy John surgeries for a 14-year-old pitcher, or ACL tears for that 15-year-old female soccer athlete that wants to get that scholarship. So I believe that wearable tech can play a role, and it's become a really important area of our work using wearables. And this is some data that I found a few weeks ago that I thought was interesting, looking at the most recent NFL draft. And about 89% of all the picks were multi-sport athletes. So this is a common notion that there's something that says you have to specialize in a sport if you want to be the next superstar, but that's absolutely not true. You kind of see from this data and plenty of other data that people who specialize in a sport can still be the best at their game. And often multi-sport performances or multi-sport athletes or participating in more than one sport is often the way to go, so that we can prevent overuse injury for those specific muscle groups. And so this is a study we've done at Case Western using on our men's soccer team. So this is actually a direct quote a coach sent to me via email one day. It says, "I want to know how my athletes are performing during practice and matches relative to each other. I have this data," so in this case, the data from the Catapult Player Tech device, "but I don't know what to do with it. And I need a way to analyze the data quickly to inform training. I am seeing spikes in injury and need a way to stop this." So basically what they did was just email us reams, about 80 sheets of Excel data. It's just massive amounts of data. It came out to about a gigabyte worth of data that we received one morning. And the coach was like, "Help me out here." So the first thing we found was, when deciphering all of this, but there was about a 1.8x difference for the specific team in workloads between practice and matches. And so we presented this to the coach, and we're like, "Coach, overall, between the various position groups, on average, we're finding this significant workload amount. That's, so if you want to prevent injuries, this is our recommendation, that you change how your practices are structured, or you make some changes to how, what you're trying to do to mitigate such injuries." And then he was like, "How are my various players performing in relation to their work groups?" So then we did a kind of a spider diagram comparing, say, a specific workload. This is for the forward position, looking at the mean workload of an athlete relative to the position group. So that way the coach has a very quick and easy way of adjudicating the data or deciphering the data. So in this case, we just want to know, is the data overlapping, right? So this is just a very dry and dirty way that we can kind of give the coach an easy manner to look at the data, just by color coding it, because they don't want to spend time having to decipher data when they want to focus on match strategy, figuring out what players are going to be showing up the next day, et cetera. So we want to make life as easy for the coach as possible. And next, we looked at one variable, the acute to chronic workload ratio, defining in this case chronic workload as 3 weeks for this specific player over a 12-week period, just to kind of give the coach a metric of where the athlete is performing in relation to the other. So this data we kind of then provided to the coach, like I mentioned, and was able to optimize his training to ensure that the workload profiles between the practices and matches were relatively analogous to each other. And going into the next season, they were able to implement this, and did see a few changes, but we weren't able to get that longitudinal data because of COVID. But nonetheless, this kind of shows that what type of communication is needed, and kind of inform collaboration between sports teams and data scientists to ultimately enable such data to reduce injury burden in athletes. And the next study we did was looking at NFL film game data. So this is a competition we actually submitted to at the NFL Big Data Bowl in 2019. And so as part of this data, we were provided GPS data from a specific game. And so what we did was create an open source algorithm to quantify player workload, in this case using the Zebra RFID tag. So this is really the first time an algorithm was published in that standpoint. And what we did also was take specific in-game data. So this is like one specific game, and this is the play. I'm going to play this video so you can look at the two simultaneously. So in this case, it's the quarterback throwing the ball to the receiver, and the receiver is going to basically run for a touchdown. So I'll see if I can play it right now for you. guess Murphy's Law is not supposed to play. Anyway, what we can see is the quarterback will throw the ball and the receiver will get that. And I'm happy to show this video offline once I can get it to work. But, kind of our next question was, how can wearables be used in a return to play protocol? And before we employed wearables, we want to know what are injury profiles in athletes following a return to sport. And so this time we looked at the Bundesliga league, so the German soccer league. And this is the first sport to return following the COVID-19 lockout. And so in this study, we looked at 537 athletes, and we found that they basically had a 1.1x odds of being injured following the lockout, with a 3.1, basically a 3.1 higher rate of injury when controlling for games played prior to games pre-lockdown. And so there are about 0.84 injuries per game post-COVID compared to about 0.27 injuries per game pre-COVID. So if you just divide 0.84 by 0.27, you get around 3.1 approximately. And what we found was muscular injuries were the most common, with about 23 injuries total. And about 17% of athletes experienced injury during their first competitive match following the lockdown. And so this is just the graph here looking at the various types of injuries that we studied. So muscle injuries, fitness-based injuries, hip, foot, back. We found that the muscle injuries across various position groups for this league were significantly higher. And so from our general conclusion that we took away from this was that there's a high injury incidence for players that have yet to complete their first competitive match, may imply suboptimal sports readiness following home confinement. So this is more of a retrospective study we did on this to suggest, what are some of this data looking at as athletes return to play. And so when we look at the opportunities for wearable technology in this regard, the return to play process is really kind of two processes. One, it's biological, and then it's functional. From a biological standpoint, how long does it take the damaged tissue to come together? From a functional perspective, how long does it take the patient to regain its strength to protect tissue and return to activity? And so what the literature has shown this is there's approximately a 10% loss in fitness with each week out. And there's a need for injury-specific and position-specific return-to-play protocols, specifically looking at it from a musculoskeletal perspective. And so this is a paper that Dermot, myself, and a bunch of others published in 2021, last year. And so what we just look at is the integration of external and internal workload factors. So external, what did the athlete do? Internal workload, what is the athlete's response to what they did? And next is the perceptual well-being. Is the athlete coping with what they're doing? And then lastly is the readiness. Is the athlete prepared to train or compete? So this is kind of a organizational workflow or operational workflow that can be employed by the athletic trainer to help guide the training over a period of time. And this performance index we can then define as the ratio of internal workload to external workload to really help boil things down if we need to one number to provide that quick actionable insight to the medical staff or to the athletic trainer on the teams. And so now looking at what some of this data looks like. So this is data that I got from the 2020 SSM meeting, which I'm sure many of you in this room have attended. So this is data courtesy Dr. Lyle Kane from the University of Alabama. So this is a specific player. So this is a running back on the University of Alabama team that tore his ACL basically on this is September 15th. This is data from 2015. And so what we're looking at using the Catapult GPS sensor, we can look at the change in distance and also the change in velocity as the athletes return to play. So this is about 6 months out. So in March, when the athlete first started to perform cutting, pivoting based exercises during his return to play process. And so thus, a significant drop in the total distance traveled and velocity. But what we found interesting is as the athlete basically returns to play from March to about April, there's a gradual increase in velocity over this period of time, which kind of shows that how such data from wearables can inform the return to play process. So this is just one example of how such data can be used when we help guide athletes back. But from an injury prevention standpoint, can we modify the training regimen when noticing specific tendencies to have, for example, lower cutting velocities, in this case off the left leg, which is the surgical leg in this case? Can the data that's acquired from technologies be used to modify injury risk for example, a non-contact ACL? And from a data science and biosensor standpoint, I like to call it the quantified self, is what data is important that we want to measure? How do we catalog this data? If we want to say predict, or if we want to forecast when an appropriate approximate return to play timeframe is for a specific athlete at a specific position in sport, what type of sample size do we need for such predictions? and what type of biomarkers can be used to kind of augment or complement a lot of the data that's currently being utilized in the clinic. For example, it's an ACL, single leg hops, ratings perceived exertion, or other types of data that's being collected. What other data can be utilized to kind of complement what's being done right now? And so I'll talk a little bit about a study we're doing that I'm working on using biomarkers for such quantification. So the data on the left is ACL tears over numerous years in the NFL. So this is a picture of an athlete with quad atrophy after an ACL reconstruction. The left leg is a surgical, the right leg is the contralateral. And so in this study, we're using a device, the Human Hex sensor that I introduced earlier. So a muscle oxygen saturation sensor to look at changes between the contralateral and surgical leg. So in this case, it's placed on the rectus femoris. And this device is basically applied with using a medical grade adhesive. And our hypothesis is that really there'll be an increase in SMO2 or muscle oxygen saturation as the athletes return to play due to working out and basically the muscle adapting during the return to play process. And so this is just sample data looking at hemoglobin levels over workouts and muscle oxygen saturation over workouts. So in other words, the total hemoglobin is a function of the oxygenated hemoglobin and the deoxygenated hemoglobin, or HB. And thus the muscle oxygen saturation is calculated based on the oxygenated hemoglobin divided by the total hemoglobin. So this is how this sensor in this case calculates muscle oxygen saturation levels. So let me present to you one case, on ongoing data. So this is data actually we got a couple weeks ago from an athlete, a 20-year-old female collegiate athlete that had a non-contact ACL tear during the 2022 preseason. So right now, this individual is about 27 weeks post-injury. So we measured the muscle oxygen saturation on her contralateral versus her surgical leg under the supervision of a physical therapist. So we're monitoring multiple parameters. I'm just going to show you muscle oxygen saturation for the purposes of this slide. We're also looking at RP and sleep as well. So in red here is the data, is the muscle oxygen saturation profiles from the contralateral leg. The blue is from the surgical leg. And what we can see here is there is a difference in the contralateral and muscle oxygen between the two. So in this case, the data is normalized to the baseline metric that we take initially. And so we found that there's a difference at the 27-week post-injury mark as for this particular athlete over this workout period, which lasted about 45 minutes. And just taking the differences between the contralateral and surgical, we can, for this normalized data, we can kind of see this difference over a period of time. So we're expanding, right now for the study, we're planning for about 50 patients. In this case, athletes ranging from about 14 years old to about 22 years old, to include the high school and collegiate cohorts, looking at both male and female athletes using the MSKI sensor in this case. So if we want to look ahead to kind of performance optimization and health monitoring, what do we want to do? So my interest really is in leveraging engineering and collaborating with folks like Dermot and yourselves to address unmet clinical needs. So my interests, for example, are in epidermal electronics, implantable electronics, to look at biomarkers and other metrics. From a clinical research perspective, looking at the efficacy of these devices is a big thing for me. Parameter integration, how do we factor in multiple data points from multiple sensors, so time synchronization of the variables for analytics development, both in healthy and compromised individuals, and then ultimately take these devices from the lab and translate them out to the real world so that patients of all ages can have access to this data. Ultimately, we want to optimize recovery, we want athletes to train smarter, we want them to train harder. There's obviously a fine balance between the two, but we want to objectify what their efficacy and make sure they're performing to their best ability. So that really undergoes performing a SWOT analysis, or strengths, weaknesses, and a threats analysis of this technology to understand its limitations and advantages, developing a minimum viable product, performing clinical verification studies, and then identifying partners that we can kind of translate this technology out with. And so there's really 4 key areas that I'm interested in. One is in the area of wound care and rehabilitation. So using this stuff for, say, chronic wound therapy as one area, or any platform to initiate angiogenesis. For example, another area that I'm interested in is in Achilles tears where there's a lack of vascularity. So for example, in the geriatric population, can safe flexible electronics help expedite recovery and initiate angiogenesis for such populations? Flexible, implantable, and transient electronic devices is another important area, and I'll talk a little bit about that in the next subsequent slides. Musculoskeletal and physiological modeling, like I've described quite a bit in this talk so far. And there's really this new area of the convergence of wearable technology and pharmaceutics to really call out this whole area of digital therapeutics. So working with pharmaceutical companies to help them quantify the efficacy of the therapeutics We've done some work, for example, in patients with atopic dermatitis to look at scratch counts using a wearable sensor to see if we can see a decrease in scratch counts over time in patients with atopic dermatitis, eczema, pruritus, or other diseases. And so for wound care, this is a device that I developed during my PhD. Just very briefly, flexible electronic device integrated to an electronics module that basically can deliver an electrical stimulation to the skin. So this is a chronic wound model that we developed in a Yorkshire pig. And we basically found that the use of the stimulus could help improve healing, or expedite healing, I should say. And so this kind of leverages advancements in polymers engineering, biomaterials, and then to basically use these wounds that are clinically relevant. So in this case, these wounds are about 6 centimeters in diameter, about 2.5 to 3 millimeters deep, to really measure, to really recapitulate what we're seeing in the clinic. And use of the Yorkshire pig model kind of mimics the vasculature and dermal properties of humans. So these are just various components of the bandage, and a conductive elastomeric electrode that's biocompatible for the skin, using the same type of adhesive that's used in a tegaderm. So we try to mimic all the same materials that are used in current medical device products today and kind of put them in a device that's, once again, biocompatible, safe, scalable for such testing. And this is, and as the wound reepithelializes or closes, we've been able to tailor the bandage to different sizes. So this is just one example of the bandage with the electronics module on a Yorkshire pig model. So this is studies at the VA, the Veterans Administration Hospital in Cleveland, where a lot of this work was conducted. And what we found is the use of electrical stimulation really expedites healing by postoperative day 10. So wound that receives stimulation are about 82% smaller by BTD or postoperative day 10. Wounds that received an inactive device were about 58 smaller. Wounds that received standard of care were 62% smaller. So we've shown that, and we've submitted this device along with this application to the FDA for breakthrough approval and starting clinical trials on this pretty soon. And so one of the applications that we've developed is a flexible substrate that I want to ultimately use for wearable applications. So we've shown that it can be unstrained, stretched, compressed, and has torsion. And so these are just can maintain its various properties when it's on the skin. So we can show, for example, for our wound dressing, clinicians want to be able to see these wounds and look at how healing occurs. So we can absorb exudate without affecting the visual properties of the substrate. And so just kind of the last area that I want to talk about is this area of transient electronics. So this is basically a conductive, flexible, and stretchable electrode that we developed. In this video, my colleagues basically stretching this electrode. And what we're recording here is a change in voltage over time. So this is a very basic science type experiment, but I'll explain the clinical ramifications of this work in the next slide. But basically you can see highlighted in pink is the change in voltage that's observed over this time period here and over multiple trials. So as a clinician, you're saying, why is this work relevant? Well, for example, one area that I'm particularly interested in based on a personal example of my grandfather is for dysphagia, sort of difficulty swallowing. Right? So dysphagia obviously has numerous complications from a musculoskeletal perspective or a neuromuscular perspective. But if we look at current devices today, they're fairly bulky. They failed really to address all aspects of swallowing. They provide wired systems. They provide biofeedback, but none are wearable and continuous. So if you can monitor strain or by monitoring the change in voltage over time, like the data I showed before, if you can integrate that into a wearable device, you can have a wearable strain sensor that can monitor swallowing in these patients. And this has applications to a wide array of different areas of medicine. For example, dysphagia, stroke, dyskinesia, or even in orthopedics for ligament reconstruction. So for example, for Tommy John surgery, can we measure the strain or the internal, or the workload that expended by the athletes as they return to play in that regard? Or even for cardiovascular implantable devices, all these materials that we've developed are biocompatible long-term. And so this is one example. I won't get too much into it, but really this is a manuscript that we've submitted to Advanced Healthcare Materials, looking at a flexible device, so a flexible substrate for patients to monitor scratch events in patients with eczema, atopic dermatitis, and pruritus. So in this case, this is a child about 5 years old with terrible eczema. And so a lot of these individuals are not able to sleep at night. And there's a direct correlation with patients with eczema or atopic dermatitis and suicide, surprisingly, because they're not able to sleep. That affects their day-to-day life. That leads to mental health illness. And so the question is, a lot of these companies are spending billions of dollars on such treatments. So can wearable tech help provide that quantifiable evidence to demonstrate the efficacy of such therapeutics over time? So so we're working with two companies right now. One is Maruho in Japan, another is AbbVie, to help looking at the efficacy of such therapeutics over time. So I just want to share one example of this device for your reference. And so lastly, really want to conclude with digital diagnostics, therapeutics, but wearables overall. We need to measure what matters, right? So what are the variables that we want to measure for the athlete or for the patient? Why do we want to measure them? Like I've alluded to before, we want to measure it well. What's the appropriate signal modality to accomplish that? And we need to adapt it to the patient. So really, I like to think about drugs don't matter if patients do not take them. Pretty obvious statement. But if we were to make a wearable, the wearable can be the most accurate wearable, it can be the most unobtrusive, it can have the best properties of the skin, adhesion, etc. But the wearable, it doesn't matter if the patients do not wear them. So to mitigate that, we need to understand what the clinical need is and standard of care. So that comes with working with people like yourselves. I believe, get the engineers into the clinic from day one. So that's something with my PhD in Cleveland, I've been very fortunate to going into the clinic, Cleveland Clinic or other hospitals in the Cleveland area to really understand what's being done. Engage early and engage often. So working with the FDA on a letter of intent or QSUB submissions to understand what are their expectations for clinical data and tailoring the clinical trials to match that. The little things matter. If we're going to design a medical device or a product, the UI, UX, the usability, the form factor, all matters because if it's not to the patient's expectations, they're not going to use the product. So these are all small things from an engineering perspective that need to be factored in right from day one. And then clinical design reviews start once the minimum viable product is ready. So bring the product to the medical team to let them figure out is it appropriate, what changes need to be made before we start scaling. So in short, what have some of the global takeaways from the seminar? One is athletes push the limits of performance. They're more willing, what we found, to adopt and use technology as a means to quantify self, and it can be a great way to kind of get that baseline data that's necessary. Two, the validation of wearable technology remains necessary before it can be fully adopted. Three, the use of artificial intelligence and machine learning models will complement decision-making protocols. A lot of people, for example, say in digital pathology that AI will replace the radiologist. I don't believe that at all. I think artificial intelligence will complement the expertise of clinicians today to help inform learnings. And to accomplish this, baseline data sets are needed to train these models to enable a high positive predictive value. The convergence of digital therapeutics and wearable technology are the new frontier. Partnerships with pharmaceutical companies is necessary for objective monitoring of patient-reported outcomes and also look at therapeutic effectiveness. And lastly, collaboration between academic, engineering, and medicine are needed to really define and revise standards. So with that, I'd like to kind of thank all my collaborators in Cleveland. Dermot's been a fantastic person to work with over the last 5 years or so, and folks really around the world that have really allowed a lot of this work to occur. So I want to thank you all for your time. Happy to take any questions.
Thanks for a fantastic talk. I know we're really short on time here, but one comment with the plea and then one question. You quoted Lau Kane.
Yeah.
The data from that catapult is this high. Nobody gives a crap. So it's got to be simplified to what's usable. He's got a very difficult coaching situation at Alabama, as you know, where they're very critical of the medical staff. All he uses catapult for is symmetry. Symmetry and return to play, so you can show those peaks. You can say this guy's ready. No, coach, he's not ready at 4 months. Yeah, he is ready at 8 or whatever. So that's one thing. The plea is to take the nerd factor out of this and understand what's important. And with that comes my question. When we're looking at training, which is what the coaches care about, Coach K would always use Tim Cell in the K lab, and we'd have 4 data points in the year so that the players would peak in March and try to minimize re-injury. What's important? We thought heart rate variability might be the best combination of cognitive and physiologic, but we don't have to measure all these things. What if you really want to distill this down to something really important for coaches, trainers, and athletes? What are the 1 or 2 things on a wearable that you really need to show where an athlete is in training?
Yeah, that's a great question. I would say from a movement perspective, like cutting and pivoting sports like basketball, for example, definitely external workloads of movement. So indoor GPS sensors has kind of been the new norm in that sense. And also, I would agree with HRV. There's been a lot of work that's been published from University of Alabama with Dr. Andrew Flatt and others in Europe that shows the relationship between neuromuscular deficits and cardiovascular using HRV. So if I had to pick 2, it'd be movements, acceleration, and HRV specifically right now. So thanks.
Well, it's been fantastic. Anybody who does clinical research and doesn't get excited thinking about all the ways that that data can be incorporated, probably surpassing PROs, which are probably the gold standard right now, and figuring out how to incorporate those better. But thanks again for coming, and really enjoyed it.
Thank you very much.
Exciting area.